Well, thank you very much. Yeah, it's such a pleasure to be with you. I do hope you can hear me all right.
Perfect.
And I hope you can. Well, that's wonderful. Otherwise, it might even be better if you couldn't hear me, because then you could just go to sleep, actually, and that might even be better. You could take a little nap before the rest of your evening's festivities. But thank you, Professor, for introducing me. It was wonderful to see my mentor and one of my great mentors, Professor Bolton, and now yours as well. And, part of these kinds of schools is the opportunity to work with and learn from women and men that you can ultimately emulate and kind of then pay it forward. And that's what's most important about all of this. And I'm so happy to talk to all of you that are getting into this field, because it's just such a great one. We give away all of our slides. I would just ask you to email me, or I'll send my copies to you, and I'll send it to Mihai or Yulia or someone, and you can just copy them and make them better and pay it forward. That's what I would ask you. And we're just going to talk a little bit about the diabetic foot. You've already heard a little bit about some of this. Some of this is going to be repetitive to Professor Bolton, but it's only because I copy everything that he does. But for you, it's a benefit because you're going to see that these ideas now are grounded in reality. There's some great relatively simple concepts and technologies out there that are moving forward. And I think whether in Cluj, whether in Los Angeles, in London, in Manchester, all of these efforts are moving forward. It's an exciting time. And we're going to talk not about tissue repair and wound healing, although we could do that maybe next time. There's so much to talk about. We're going to talk about remission, about preventing these things, and about ulcer-free days. How does that sound? So this is what I do. I am a foot doctor, like many of you now, or are looking to be. And I can think of two great gifts, two gifts that you can get by working out at the end of the body that I think about every day. And the first is this, when I can't think of anything that's more of an expression of humility than looking after the foot. It transcends all borders and religions and ethnicities. And if you think about it, even time, tending to someone's feet is to itself an expression of humility. And in this era of hubris and people thumping their chests, it's pretty good. I think it's a good thing to be on the humble side of that. And the more we work in this area, either on the vascular side, as you hear with Mihai, or on the foot side of things, it makes you humble. And I think erring on the humble side is important. So that's one gift. The other great gift is when you're on this peninsula, on this anatomic peninsula, you get this great gift of perspective, and you hanging out there, and you could start to collaborate. It forces you to be multidisciplinary or interdisciplinary, whatever the translation, and to collaborate with the anatomic mainland. And this big idea is really important when you're working out there on the foot, because as you heard Professor Bolton say, about observation toward the end of his lecture, you're not just looking after the foot, you're looking after the whole patient who happens to be connected to the foot. And so this is very, very important to kind of move forward as we discuss this. So let's kind of blast through this. I don't even know how much time we have. I'm not going to take all the time. I'll do my best. I think Professor Bolton may have just texted me or something or other. But the bottom line is there's a lot in terms of perspective. There's unfortunately, this current perspective makes us humble because this foot complications in diabetes are common, complicated, and costly, no matter where we are in the world, whether we're in Romania, whether we are in the UK, whether we're in Africa, South Asia, or the United States. Look at this. So these are really intriguing data. It's from already now 10 or 15 years ago, but it's an interesting trend. You see these data just reported last year from the 10 years previous. But you see that in France, they reported that there was a steady a leveling of diabetic or lower extremity amputations, or maybe a slight decrease, but fascinatingly, an increase in diabetic foot ulcers from these really lovely data from Amadou and coworkers. And in different countries, you might see different sorts of data, but this is pretty encouraging. There are many countries that are having increases in amputation, but that increase in ulcers is a fascinating one because if we think about this, like maybe we would have thought about cancer a generation ago. Cancer rates, cancer deaths started to decline maybe in the 1990s, but there are more people with cancer. So it's like a numerator and a denominator. And so we are going to have a lot of work ahead of us to try to not only heal those wounds, and we don't have time to get into all the wound healing things that we're talking about. Maybe next time we'll talk about all the technologies there, but preventing them and extending ulcer-free days is really pretty important, even more important now than ever. So let's keep going in all this as we sort of continue with a little bit of bad stuff before we talk about a few of the good things that we can do as podiatrists, as podiatric surgeons, et cetera, et cetera, et cetera. And if you look here, this technical review I wrote with Professor Bolton, we know that every second now around the world, someone develops one of those diabetic foot ulcers. And this is getting worse, not better, as we saw. We also know that every 20 seconds now, someone around the world has an amputation. So it seems like time is against us, no matter what time it is where we are watching this. And so we'd like to think that time's up, time's up for a lot of things, but I think for amputations it is. And it might be a really good thing and kind of a humble thing to say that maybe you could dedicate your life to looking after this humble foot and trying to help people move through the world a little bit better. And I think that's a good time to do that. I'm excited that you guys are doing this in Romania and frankly beyond, because you can really make a difference. But again, there's still a lot of bad here, and it's not fair to compare one bad thing to another. But let's just do this as an exercise, if you don't mind, before we just get into a couple of technologies that I'm certain that you're going to be using soon. But let's talk about the diabetic foot and cancer. The thing is that very few people care about feet beyond this Zoom call. Maybe some people care about diabetes, but not very many. Unfortunately, it's getting better because Professor Bolton is the president of the International Diabetes Federation. But a lot of people care about cancer. We all have family members that have survived or have succumbed to cancer. And so let's do this exercise. We don't have time to go through all of this, but the fact of the matter is that if we look at the best available data now on mortality, these data from last year, we revisited this study that we did maybe 15 years ago. We see that it's not very good. If we look at people with diabetic foot ulcers, minor amputations, major amputations, lung cancers, these problems, even the most conservative numbers, are at least as bad as a bad form of cancer. And we would never think of withholding therapy on a patient with breast cancer or lung cancer or colon cancer, but it happens all the time in people with foot problems. And so I think the battling against pessimism and negativity, either in Romania or in anywhere else in the world, is really important, especially when you're starting a new specialty like you are now with podiatric medicine. So let's keep on now with this sort of thing. And let's now talk about not just foot ulcers, but their recurrence. In this manuscript that we had a couple of years ago, you may have already seen this from Professor Bolton, but if we look at recurrence in this population, we have to ask ourselves, are we using the right language? And I'm not talking about English versus Romanian versus Esperanto. I'm talking about the real language in describing this, because after healing, about 40% of people are going to have a recurrence at 1 year. It is about 2/3 at 3 years, and maybe 3/4 at 5 years. So again, being humble here, we have to ask ourselves, can we really heal anyone? Maybe that's not the right language. Maybe that's a little bit too much hubris. I tell my trainees in the operating room, I just did last night, that nothing ruins a good surgical result like follow-up. And the wonderful thing about podiatry, and the wonderful thing about vascular surgery as well, by the way, is that we follow our patients from the beginning until the end. But again, recurrence in this population is not only common, it's likely. So if the foot in diabetes is a little like cancer, then maybe when people are healed, maybe they're not healed, maybe they're in remission. And I would give you that tip to use the next time you're talking to your patient, whoever he or she may be. You can use this term, and they seem to get it because you talk to them and you tell them that wounds in diabetes will, not can, they will shorten their patient's life, just like with cancer. And you see the patient being uncomfortable, you're uncomfortable, but then you tell them that you're not healed, you're in remission, and you still see them being uncomfortable because you've used the cancer terminology. But then you tell them, our goal now, because it's almost certain you're going to get another ulcer, is to make that ulcer less complicated and as short-lived as possible. And here's how we're going to do it. We're going to get you in the right shoes. You're going to come back to us in podiatry, vascular surgery, other teams in endocrinology and diabetology, and we're going to get you on the right diet. We have this dietitian here. We have the right shoes for you. And then you see them relaxing a little more, but now this problem is front and center in their mind, or a little bit further in front of their mind, and not just crossed off of a list. So again, that's probably the most important thing that I can talk to you about today. You can now go to sleep for the next 5 or 10 minutes and catch up on your stuff for tomorrow morning. But let's talk about now just a few technologies, just a couple of them. We don't have time to get into some really cool stuff, but we can maybe talk about preventing severe recurrence, even if we can't prevent all recurrence. How about that? Let's do it. So you've already heard this to some extent, I think, but there's sort of an algorithm. There is something of an equation to treating diabetic foot wounds. And in the face of peripheral sensory neuropathy, you see that one has pressure, and we can modify pressure externally through shoes, insoles, casting, braces. We can modify it internally through surgery by changing the way their foot hits the ground. You heard a little bit about this, or even through physical therapy, or since Yulia is here, physiotherapy. And we can also modify activity And in the past, we haven't been able to modify activity. But what's really cool with newer technologies is that we've been able to modify activity by changing and dosing activity like we would dose a drug. And we don't have, again, we don't have time to talk about this today, but this is something I think that in podiatry, you're going to be doing a lot. You're going to be sort of activity doctors in a lot of ways, working with your friends in physical therapy as well. So it's really, if you think about it, it's an activity and pressure imbalance. And we have to bring that imbalance back into balance surgically and medically and mechanically. And I think podiatry does that well as other specialties. But let's talk about this very, very briefly in the time that we have left, because I had already mentioned that we can maybe dose activity like we dose a drug. And I thought that this might be important many years ago. This is one of my oldest slides. I think I made this when I was a student. But I thought that that we could dose activity like we dose an antibiotic or another drug, too high and you have toxicity, too low and you don't get the benefit of the drug. And the same thing with activity, with too high and you get an ulcer, too low and you don't get the cardiometabolic benefit. But we could possibly improve the number of steps someone could take surgically or medically or through topical agents, and help someone take a few more steps every day. This was sort of the humble concept. And I think it's happening now. It's pretty exciting that there are certain things that are really working. And you heard Professor Bolton already talking about these kinds of things and about, humility and about your mentors. And these are two of my mentors. And so this is, you don't see my arrow here, that's okay. But in the middle of this picture is Professor Paul Brand, and he's sort of the king of the sort of insensitive foot. What a wonderful man. He treated people with leprosy and then with diabetes, and he's forgotten more than most of us know. Similarly, to his right and our left is Professor Bolton. You've already heard from him. And that's me on the right. This is like 15, 17 years ago. But Professor Brand has passed away about 17 or 18 years ago, as it were. But, what he said back then is just as important now in terms of new technologies. And you heard a little bit about this from Professor Bolton already. He said, wounds will heat up before they break down. And he was absolutely right. If you want to sound smart, and by the way, who does not want to sound smart, whether in Romania or here in the United States, in Los Angeles, all you have to do is take a sip of whatever you're drinking, and just take a sip, and then look at your friend when you're talking to him or her, and just say inflammation, and walk away, and you'll be right. It really doesn't matter what you're talking about, as long as you're talking about something to do with human health. But inflammation and uncontrolled inflammation is the bane of our existence. And trying to bring that lack of control into control is really important. But the cool thing is, if you will, we can identify it now. And there's all kinds of gadgets that we can use that are relatively inexpensive, that we can have available to us. What you can see here is on the left for you is just in our clinic, and this is just my phone, my iPhone. But you can also use an Android device, and there's a little camera now that attaches to the bottom, and we use this every day in our clinic. This is identifying a Charcot joint, as you see here, but we can identify ulcers and even ischemia or relative ischemia and other complications, just looking at that asymmetry. And we can be very, very sophisticated in how we count that. So again, Professor Bolton or I should say Professor Brand being correct, you see these data from 10 or 15 years ago, where we had a randomized controlled trial looking at thermometry, giving people thermometers to dose their activity by checking their skin temperature, just as they might dose their insulin by checking their glucose. And it was pretty great because we saw these asymmetries that predicted these foot ulcers, indicating that we could really make a difference. And the data already are very strong that we can lower risk for reulceration. And we now give our patients guidelines to return to activity. As you see here, this is from our blog. We give out instructions for our patients to return slowly to activity just by using even a very inexpensive $20 activity monitor, a $10 US thermometer, and a simple recipe. But we're getting better. We don't have time to talk about this, but we have so many different intelligent textiles we've been working on now for the last 15 years. Smart socks are a thing now. They can identify not only temperature, but pressure, and even joint angle with some of the ones we have in our lab. I think you guys are going to probably be using things like this if you haven't played with them already. And you're going to help to be able to dose activity pretty well and identify complications before they occur or recur. People now have taken that idea and made entire companies out of it. About 20 years ago, I wrote a paper saying that maybe we could subscribe to our shoes and our socks and our insoles like we would subscribe back then. It was to our satellite TV or our cable TV, but now it would be like to our Hulu or our Netflix or our Spotify or what have you. All of these ideas are true, and I think this is now happening with socks from a company with a young lady named Ran Ma, who spent a little bit of time with us. She and her friends started a company, and they then took this idea. It's just socks. I don't think you can get less sexy and more humble than socks. And they took it to Las Vegas in the United States, which is not very humble. And they competed up against all of these very fancy gadgets and technologies like virtual reality and augmented reality. And in this competition at this very big symposium on technology, reality ended up winning. And so it was awesome. This is so great. And so you see this happening now. The humble sock is now becoming a pretty cool gadget now. And we're starting to see a lot of this sort of merge, consumer electronics and medical devices. We now have a very big grant from the National Science Foundation to do similar things, to extend care in the home with all kinds of different technologies. But this is now something where we're seeing consumer electronics and medical devices become inseparable. That's really the big idea. And you're going to be dealing with this as clinicians for the rest of your careers. So, ladies and gentlemen, I'll just conclude with this. You saw some very nice quotes from Professor Bolton. I'm not going to provide you with anything as fancy as that. I long ago realized, don't even try to compete with that one. But what I will do is this. When I was a kid, I loved to play soccer, and I was a goalkeeper my whole life, all the way through university. And I still, if you're a goalkeeper, you let one ball through your legs, and you can stop 19 or 20, and you are not the hero. Everyone hates you. Whereas your friend who's the striker, he or she can take 20 shots and make one, and he or she is the hero. But I've always felt like the goalie, and I still feel like a goalie in clinic. And I saw this video, and I wanted to share it with you, especially after the Euro Championships. I'm sorry, Professor Bolton, but I'm going to show you this. And so, oh, yeah. So when I saw this video, a while back, I thought to myself, that's me. You know, of course, not the striker, but the guy in the goal, you know, looking stupid, but still somehow in position to make a save. And it made me think of a great quote. And let me share this with you. I hope it translates. And if it doesn't translate, that's okay. But this is from Mason Cooley, who almost 100 years ago said, if you position yourself well enough, circumstances will do the rest. And I believe that's true. I believe that's why we all come together, no matter what our specialty, to maybe position ourselves better in the world with our friends, to try to make a difference. And I think that's the big idea. If we can do that, then maybe we can help our patients move through their world a little bit better every day. I think that's the humble thing to do. That's the perspective. And ladies and gentlemen, Mr. Chair, Madam Chair, thank you very much. It's such a pleasure, an honor to start my day with you.